Welcome to the deep dive.
Okay, today we're really getting into something specific and important for medical revision. Subacute thyroiditis. You might know it as D. Quervain's.
That's right.
We're basically aiming to pull out all the key high-yield stuff from the revision notes, make it stick.
Yep, our mission, if you like, is to get a really solid handle on this condition, what it is, why it happens, how it shows up, and, crucially, how it's managed. We've got the notes covering everything from the definition right through to prognosis.
Perfect. So think of this as your focused session to really nail subacute thyroiditis. Let's jump straight in. Definition first. What's the absolute core concept here?
Okay, so at its core, it's an inflammatory condition of the thyroid gland. And the really key thing, it's self-limiting. It gets better on its own usually.
Self-limiting, okay. And it presents with specific things.
Yes, the classic picture is acute pain in the thyroid area, some swelling, a goiter, and then this really interesting pattern with thyroid hormones. First, you get hyperthyroidism, so too much hormone.
Right, the overactive phase. Exactly. Then that's followed by hypothyroidism, the underactive phase, before it typically settles back to normal.
Got it. So a temporary upset, essentially. Any other names we need to know?
Yeah, it's often called de Quervain's thyroiditis, as you said, or sometimes subacute granulomatous thyroiditis. And one more pointer, often there's a link to a viral infection just before it starts.
Ah, okay. That's a useful clue. The notes mention 4 phases. Maybe walking through those would help kind of map it out.
Definitely. Good idea. So phase 1 lasts about, say, 3 to 6 weeks. This is the hyperthyroid phase. That's when you've got the painful goiter. And blood tests often show a high ESR. That's a general marker of inflammation.
Okay, 3 to 6 weeks, hyperthyroid, pain, high ESR. What's next?
Phase 2 is usually much quicker, maybe 1 to 3 weeks. It's called the Euthyroid phase. Basically, things are kind of in transit. Thyroid function tests might look normal for a bit.
A brief calm before the next stage.
Sort of, yeah. Because then phase 3 kicks in. This can last longer weeks, sometimes even a few months. And this is the hypothyroid phase. The thyroid's sort of exhausted after the inflammation.
Underactive now.
Right. And then finally, phase 4 is recovery. And, the good news is most people, the vast majority, get back to completely normal thyroid structure and function.
Okay, that timeline makes sense. Hyper, then maybe normalish, then hypo, then recovery.
Yeah.
So what actually causes this inflammation in the first place? The etiology.
Well, like a lot of things in medicine, the exact cause isn't completely nailed down, but the strongest link, the likely trigger, is thought to be a viral infection.
Ah, that viral link again.
Yep. The notes mention things like coxsackievirus, even mumps virus as potential preceding infections.
So the idea is the body fights off a virus and then the immune system sort of gets redirected.
That seems to be the thinking. The inflammation is likely the immune system's response, maybe an over-response or a misdirected response following that viral trigger.
Are some people more likely to get this than others? Any risk factors identified?
Yes, a few things pop up. Having had a recent viral upper respiratory tract infection is a big one, which fits nicely with the viral trigger idea.
Makes sense.
It's also significantly more common in women than in men. And interestingly, having a background of other autoimmune conditions like Graves' disease or Hashimoto's seems to increase the risk too.
That autoimmune connection is interesting. So let's go a bit deeper. What's actually happening inside the thyroid gland, the pathophysiology?
Okay, so fundamentally, it's an autoimmune-driven inflammation. That viral trigger we talked about probably sets it off. It leads to the release of pro-inflammatory cytokines. These are like chemical messengers calling the immune cells into action.
The cavalry arriving?
Kind of, yeah. Immune cells are recruited to the thyroid gland. But here's the problem. They start damaging the thyroid follicular cells. These are the cells that actually make and store thyroid hormone.
And the damage causes problems.
Exactly. When those cells are damaged, all the stored thyroid hormone leaks out quite suddenly. That's what causes that initial hyperthyroid phase, a big dump of hormone into the bloodstream.
Ah, okay. So it's not making too much hormone. It's just releasing stored hormone.
Precisely. And then as the inflammation carries on and more cells are damaged, the thyroid's ability to make new hormone is temporarily impaired. That leads to the later hypothyroid phase while it recovers.
That explains the phases really clearly. Damaged hormone release, hyperthyroidism, then impaired production, hypothyroidism.
Okay. Now, someone comes in with neck pain, maybe feeling unwell. How do you tell this apart from other things, the differentials?
Super important, this. There's quite a list. You've got to think about bacterial thyroiditis. That's usually much nastier, more like an abscess, often very localized pain.
Okay, bacterial is different. What else?
Subacute lymphocytic thyroiditis, sometimes called silent thyroiditis. He can have similar hyper then hypo phases with the hormones, but crucially, it's usually painless or much less painful. Silent is the clue there. Right, pain is a big differentiator for D. Quervain's.
Definitely. Then you've got the big autoimmune players. Graves' disease causing hyperthyroidism, but the mechanism is different, often involves eye signs, and radioiodine uptake is high, not low. And Hashimoto's thyroiditis, which is the common cause of chronic hypothyroidism, usually not painful like this, and the course is different.
Okay, so Graves and Hashimoto's are usually quite distinct.
Generally, yes. Also need to consider acute suppurative thyroiditis, another infection, often bacterial, quite severe. Maybe just generic infectious thyroiditis. And even though de Quervain's is autoimmune, you distinguish it from the chronic, usually painless Hashimoto's type of autoimmune thyroiditis. And don't forget simple thyroid nodules, which can sometimes cause pain.
So a fair few things to rule out based on the specifics of the presentation, especially the pain and the timeline. How common is de Quervain's overall epidemiology?
It's definitely less common than Hashimoto's. The notes actually classify it as a rare condition overall.
Oh, really?
Yeah. And demographically, it predominantly affects women, typically in the 30 to 50 age range. So think middle-aged women, but it's not something you see every day.
Good to have that context. So let's picture the patient walking in. What are the classic clinical features we're looking for?
The absolute hallmark is that sudden onset of neck pain, specifically over the thyroid, which is often tender to touch. They'll usually have a noticeable swelling there too, the goiter.
Pain and swelling. Got it.
Plus, they often feel generally unwell, feverish, tired, malaise, a bit like they're getting the flu. And then you layer on those hyperthyroid symptoms from that initial phase. Palpitations, maybe losing weight without trying, feeling hot and sweaty.
And these symptoms usually resolve.
Yes, that's the key. They generally clear up within a few months as the condition runs its course. The notes specifically pull out things like myalgia, muscle aches, and pharyngitis, sore throat, sometimes accompanying that initial thyrotoxic viral-like phase, along with tremor and heat intolerance.
What about the hypothyroid phase? Do people feel symptoms then?
It's interesting, often they don't. They might be technically hypothyroid on their blood tests, but actually feel okay, or maybe just a bit tired. So symptoms can be subtle or absent in that phase. Monitoring the bloods is key.
Right. So speaking of blood tests, what are the crucial investigations?
Thyroid function tests, TFTs, are number one. You track the pattern. In the hyperthyroid phase, TSH will be very low, suppressed, because the pituitary gland senses too much thyroid hormone. T4 and T3 will be high.
Okay, low TSH, high T4, T3, then?
In the hypothyroid phase, it flips. TSH goes high because the pituitary is trying to stimulate a struggling thyroid, and T4 and T3 might be low or low normal. Then, in recovery, everything should normalize.
That pattern is quite distinctive. Any other tests that really clinch the diagnosis?
Yes, the radioiodine uptake test is very helpful. During that initial hyperthyroid phase in de Quervain's, the uptake of radioactive iodine by the thyroid is characteristically very low.
Why is that significant?
Because the inflammation stops the thyroid cells from taking up iodine properly, even though there's lots of hormone leaking out. This is the opposite of Graves' disease, where the thyroid is overactive and sucking up lots of iodine, so uptake is high. Low uptake plus hyperthyroidism strongly suggests de Quervain's or another destructive thyroiditis.
That makes sense. A key differentiator.
Exactly. Thyroid scintigraphy, a type of scan, shows the same thing, reduced uptake. Inflammatory markers like ESR and CRP are usually elevated, confirming inflammation, but they're not specific. Could be raised for many reasons.
And biopsy. Needed often.
Generally, no. Usually, the clinical picture and the TFTs plus maybe the uptake scan are enough. Biopsy is reserved for unclear cases.
Okay, we got the diagnosis. How do we manage it? What's the UK approach?
The main thing to remember is it's often self-limiting, so management is primarily focused on symptoms. Many people with mild symptoms might not need any specific prescription treatment at all.
So just watchful waiting sometimes.
Pretty much. For the thyroid pain, which can be the most bothersome thing, NSAIDs like ibuprofen or naproxen are the first port of call. They help with both pain and inflammation.
And if NSAIDs aren't enough or things are more severe?
If the pain is really bad and not controlled by NSAIDs, or if the patient develops quite symptomatic hypothyroidism later on, then corticosteroids, like prednisolone, might be used for a short period. They are much stronger anti-inflammatories.
Steroids for tougher cases. What about the hyperthyroid symptoms?
Ah, yes. For things like palpitations, anxiety, tremor caused by the excess thyroid hormone in that first phase, beta blockers are really useful. They don't fix the thyroid inflammation itself, but they block the effects of the hormone on the body, making the patient feel much better.
So symptom control is the name of the game. Let's break down treatment by phase again, just to be super clear. Thyrotoxic phase.
Right, thyrotoxic phase. First line for pain is NSAIDs. If that fails, consider high-dose corticosteroids. For the actual symptoms of too much thyroid hormone, the racing heart, the shakes use beta blockers, or maybe calcium channel blockers as an alternative. Keep hydrated. Very rarely, for severe thyrotoxicosis, you might see potassium iodide plus prednisolone used.
Okay, and then when it shifts to the hypothyroid phase.
In the hypothyroid phase, treatment is only needed if the patient is symptomatic, or if their TSH level goes very high, the notes suggest a threshold like TSH 15. If treatment is needed, it's standard levothyroxine, just like for any other cause of hypothyroidism, but usually only temporarily.
Temporarily being the key word there. What about non-drug approaches?
Absolutely crucial. Reassurance is massive. Explaining that this usually gets completely better is really important. And monitoring during that hypothyroid phase, checking TSH and asking about symptoms every, say, 4 to 6 weeks, is standard to see when or if levothyroxine can be stopped as the thyroid recovers. Remember, the notes say I 90% make a full recovery, often without needing long-term treatment.
That high recovery rate is definitely reassuring. So, brings us to prognosis. Sounds like it's generally very good.
Excellent, yes. It's a self-limiting condition for the vast majority. Most people recover fully, usually within a few months, symptom-free, normal thyroid function, no lasting issues.
That's great news. Are complications something we need to worry about much?
Thankfully, complications are rare. Very occasionally, someone might have persistent thyroid dysfunction, either hypo or hyper, or it might recur later. Thyroid nodules could develop, but things like a thyroid abscess or permanent hypothyroidism are really very uncommon.
Okay, good to know they're rare. Right, let's try and summarize the absolute must-know points about subacute thyroiditis for revision.
Okay, key takeaways. It's inflammatory, self-limiting, think painful thyroid, think viral trigger often beforehand. Remember the phases. Hyper, maybe euthyroid, then hypo, then recovery. Diagnostic clues, that distinct TFT pattern, and especially the low radioiodine uptake during the hyperthyroid phase. And finally, prognosis is generally excellent.
Perfect summary. Getting those core ideas locked down is so important. And maybe, for you listening, a final thought. As you study other inflammatory conditions, try comparing them. How does the temporary inflammation here in Quervain's differ from, say, chronic inflammation elsewhere? Making those connections can really help things click.
That's a great learning strategy. And of course, if you're prepping for the MSRA exam, do check out the resources available past them. MSRA.com and freemsra.com have loads of useful stuff.
Definitely worth a look. Well, that wraps up our deep dive on subacute thyroiditis. We really hope that's helped clarify things and made it a bit more memorable for you. Thanks for joining us, and all the best with your studies.